Premal Naik, who has probably published the largest series of Sprengal shoulder in the literature. And I would, without wasting time, I would invite Sheenam and me to start the proceedings of the meeting. Welcome, Premal bhai.
Thank you. Morning. Good morning, everybody.
Thank you. Yeah, Sheenam, you can go.
Okay, sir. Good morning, everyone. On behalf of Team Orthokids, I would welcome today's speaker, Dr. Premal Naik, sir, and all the participants for the discussion on a very interesting topic, that is Sprengal's shoulder. Let me introduce Dr. Premal Naik, sir. Sir has done MBBS and MS from NHL Medical College, Ahmedabad. Then sir has done Pediatric Orthopaedics Fellowship under Ashok, sir. Then sir done fellowship under Professor E.H. Lee in Singapore. Now sir is running his own hospital. Sir has recently published a paper on Sprengal's shoulder. They have also described a surrogate clinical test to avoid potential neurological injury in the absence of neuromonitoring. I found it very interesting. Sir, you can start.
Thank you, Sheenam, for further words. And without wasting time, I just want to know that how many people here has assisted a Sprengal surgery. We have a small crowd, but you can just show your hands, here.
Sir, I have assisted one case.
Yeah. So, anyone else wants to unmute himself or herself and let me know how many people have assisted a Sprengal surgery?
So I am Dr. Nishan Chauhan. I also assisted a Sprengal surgery.
So 2 people. So let me start with a small story. That my journey with Sprengal shoulder was also little tricky, I would say. So I got to learn about Sprengal shoulder when I was a second-year resident. There was one clinical meeting in which a Sprengal shoulder case was being presented. And that's when I learned that there is something called congenital undescended scapula. And then when the result was being presented, I was told that the child developed brachial plexus palsy and it's a very bad surgery and you shouldn't be doing it. The second instance was when I was a third-year resident. One of my teachers who had recently learned the method of Elizaro, he put wires in scapula and he tried to bring it down by putting one ring in scapula and one ring in iliac crest. And somehow I never found that reference during my research in this paper. So with these two surgical experiences, I finished my residency and then I was working with a senior orthopedic surgeon. And a child with Klippel-Feil syndrome was posted for surgery. So in that fellowship, we were examining patient and child was being anesthetized. Unfortunately, that child could not be intubated, and unfortunately, we lost the child. Actually, we lost that child just before we started a surgery. So that is how, unfortunately, was my journey with Sprengal shoulder. So by the time I got my first patient, say I think 2004, I had never assisted a single surgery. So when the first child came, I requested my senior colleagues, Dr. Prakash Amin and Dr. Jyotindra Pandit, to come and give me a hand. So it was only reading from textbook and having 2 senior surgeons with me, I embarked on journey. And from there, I've had an opportunity to do 74 Sprengal surgery, which is quite a number in itself. So let's see what happened during the journey after I started treating Sprengal. So just for a historical and theoretical thing, as many of you are street trainees, we must remember the scapula is always in cervical region and it starts coming down at end of 12th week. And if it does not come by 12th week, you should be able to diagnose antenatally. There is one report in which antenatal diagnosis of Sprengal has been reported. So what happens in Sprengal is it doesn't come out. And whenever there is an impediment to its descent, the final position is not achieved. And in that region, generally the scapula is hypoplastic, elevated, which is known as the Sprengal shoulder. And there is an associated issues with bone, cartilage, as well as muscles. It's more common on left side. I think fairly about 70%. Female is fairly more common. Bilateral, I have seen few cases, but they are very, very cosmetically accepted and they are functionally more disabling. And unfortunately, not a single patient in my series, a bilateral case was ready for surgery. I think Sandeep has few cases in which he has operated bilateral spinal shoulder, but unfortunately, I haven't operated many bilateral shoulder. So the Sprengal's first description came from Germany in way back in 1868 by postmortem dissections. Willett and Walsham, few years down the line, they published what is the anatomical issues with this condition in a postmortem. Sprengal and Kolliker, they were friends and described the first case of this congenital undescended scapula in 1891. And Kolliker, being a friend of Sprengal, gave this condition name of Sprengal shoulder. But both of them have equal contribution in making this condition famous to all of us. And in 1972, almost 100 years down the line, Cavendish, a British surgeon, he reviewed 11 and 112 cases gathered from all around England, and then he gave his clinical classification, which is still used today. So this is Otto Rural Carl Sprengal. He passed away at the end of First World War, 1950. The Sprengal shoulders patients generally have two main problems. One is cosmetic and second is functional. Abduction is usually significantly restricted depending on what is the amount of the rotation and whether the child has Klippel-Feil syndrome or not. The second thing is, if you do not treat, the report says that it becomes painful, but unfortunately, I haven't had a case in which I have found a patient with a painful Sprengal shoulder, even if they have presented neglected. But I think in my practice, what is most common presentation is cosmetic appearance. People don't like bump coming out from their neck. And in girls, generally when they wear clothes with shoulder strap, that shoulder strap and the school bag falls down from that shoulder. And that is one of the very classical complaints which I've seen in my clinical practice. So typical presentation, as you can see, is about between 6 to 10-year-old child coming with a swelling in the shoulder region like this. If you see, obviously there is a significant difference here. So you can say that this is a Cavendish grade 3 Sprengal shoulder. When you examine the abduction will be restricted. And when you take an X-ray, you will find that scapula is jutting out above the rib cage. So there has been an interesting study by Choi group published in JPO 2000 where they studied CT scan and compared involved scapula with normal scapula. What they found is that this involved scapula is short, but it is broad. So if you say this is a triangular scapula, this is maybe about a rectangle or a squarish scapula. And if you see this, this normal scapula is vertical border, while the scapula of the affected side is generally curved on the upper side. There is a very interesting theory in this particular paper, which I will show you later. Another most important diagnosis which you should make and which has a surgical bearing is whether there is a homovertebral bar or not. This homovertebral bar it could be congruous, can be osseous, and very rarely it can be fibrous, which is present in the region of the rhomboid, or which is a rhomboid or trapezoidal in shape, and it is generally in the upper rhomboid muscle region, which connects upper border of supromedial border of scapula or a spine of the scapula to the lamina or transverse process of cervical vertebra. Incidence is about 20 to 50%. One paper has described 2 homovertebral bars, and one paper has described homovertebral bars going all the way to occiput. There are a lot of papers which say that you should do a CT scan to diagnose this, but I'll show you what other methods you can have to diagnose this virus presence. Going back to the same paper, Choi et al. In the same paper say that normal caudal migration of the scapula takes in an oblique fashion like this. If this is the midline, the scapula migrates obliquely downwards and laterally. So if there is a tether which is present medial to the line of migration, the scapula does not come down, but at the same time it is rotated. And when the tether is in the line of migration of the scapula remains elevated and it does not rotate. So when there is a high elevation, you have got good abduction. When then you have a extreme rotation, the abduction is significantly restricted. So if you look at these two children, both of them have Sprengal shoulder. But if you look at the scapula, here the scapula is straight and not descended. On the left side, scapula is undescended, but there is significant rotation, and that child will have more abduction issues compared to the child on the left side. Here you can see that its scapula has not descended, it is seen upwards, but its scapula is more rotated. It is slightly subtle on X-ray, but they have more issues with their movements. So what do you look for in Sprengal shoulder? There is a defect in the upper dorsal vertebrae, and many of the patients come to me with MRI for this region having abnormal vertebrae. Irregular vertebral segmentation could be found. There will be multiple hamus or unsegmented bar. There may be spina bifida in upper cervical region or in this thoracic region. First rib is generally abnormal, and that sometimes leads to issues with brachial plexus when you are treating this condition. There will be rib fusions, at the same time chest wall deformity, and as you see here, there may be a huge gap in the rib, so that is a rib defects which you can see. As I've shown you that it can be bilateral, you can see this adult female came to me just for consultation. She was advised surgery multiple times by a few other orthopedic surgeons, and she never bothered to undergo surgery. And unfortunately, I have no experience of treating bilateral spinal shoulders. Associated muscles have a lot of issues. I'll show you operative pictures where there is a significant of trapezius, rhomboids, levator scapulae is very short. Serratus could be involved. Act major and minor, generally we don't touch, we don't see, but they have issues on MRI. Leg dorsi again is not significant, but is not normal. Sternocleidomastoid sometimes can be involved, and there can be minor torticollis, as I will show you in one of the cases. What are the associated problems? Cleft lap palate, tether cord. A tether cord I have reported, we had about 3 or 4 or 5 cases of tether cord in our series, and diastomatomyia is one of the common things. So whenever you get a child with the shoulder, you should always take whole spine X-ray, and in this X-ray you will be able to see that there are multiple fusions. NR is open on this side, and these are the children who must first go for spinal correction followed by Sprengal, because if you do the Sprengal surgery, then this spinal thing which is an occult, they will not go for that surgery and they can have long-term repercussions. Multiple syndromes associated, the most common being clipper fail, and clipper fail are very difficult to treat, difficult to intubate, as I said in earlier. So diagnosis of clipper fail with cervical spine, range of movement exercise, length of cervical spine, and cervical spine lateral X-rays is very, very important. Cavendish grading, as I said, one is in which shoulders are almost level, and if the child is dressed, you won't see it. In 2, shoulders are level, but when the dress is worn, you will be able to see that lump in their neck. Third is when scapula is about 2 to 5 centimeters higher, and fourth is when the scapula does not come down down at all, and it is in the occipital region. In my experience, in my paper, I have reasoned out that I never had a child in which there was a type 4 Sprengal shoulder, but multiple other papers have mentioned I think I've never seen a scapula which was touching occiput. And if you go by the strict standard, there is a doubt whether grade 4 Cavendish exists in literature or not. This is an example of a right-sided Cavendish grade 1 deformity where scapula is slightly higher, slightly prominent, and when you ask them to push against wall, the scapula will be prominent many a times. Even surgery was not done. If you look at this X-ray, there is a mild elevation of the scapula on the right side, but this is cosmetically not having any issues and has excellent functional issues and functional of shoulder. So these children generally do not require any treatment. Investigations, multiple investigations have been suggested. In my opinion, only X-ray is sufficient. CT scans are recommended to check whether scapula, what is the shape of the scapula, whether homovertebral bar is present or not. An MRI is again recommended to rule out associated spinal dysraphism or if there is a cartilaginous or fibrous homovertebral bar. I feel when you are operating a child and a homovertebral bar, if you are not diagnosed operatively, if you encounter, you can just cut it and you don't need a fancy investigation to diagnose whether you have this present preoperatively or not. Another recent classification, which is a radiological classification depending on where the scapula lies radiologically, is Rigaud's classification, which is a French classification, where grade 1 is when the supromedial angle is below T2, grade 2 is between C5 and T2, and grade 3 is above C5 transverse process. So this is again a research methodology. This is mainly methodology and it does not have much clinical thing. So investigations, the choice of investigation in my opinion is only X-ray. CT scan is generally when I look at it when the patient brings along from previous surgeon, and MRI when I find that there is a possibility of spinal dysraphism. I get it done in the lumbar spine and generally with the screening of whole cord. Visualizing homovertebral bar. Look at this child. If you look at carefully, there is something here, which is with little bit of experience, you will be able to see that. And when you get an oblique X-ray, where you tilt that tube about 20 to 30 degree, get the hair, jaw of this scapula, you will be able to see homovertebral bar and you will be able to plan it. I don't think CT scan has significant role in planning scapular surgery for spinal shoulder. Again, there are so many controversy, one of which is timing of surgery. There is no consensus. Most authors advocate between 3 to 6 years, and there are so many authors which will say that after 6 years we should not do surgery. But in India, I don't think any of the authors would agree to that 6-year cutoff because majority of our patient comes after 6. There are people who have advocated surgery as late as 17 years, but generally most of the patients at this age are adapted to their deformity and hardly would come. But one of the most important thing is outcome is neither influenced by age of the patient or time of the surgery, or it is not even influenced by whether there was a homovertebral bar present or not. So now let's look at what are the treatment options. Initially, people started just excising homovertebral bone and left the scapula alone. There were few people who went ahead and excised homovertebral bar along with supromedial portion of the scapula, which was coming out in the neck region, leaving the scapula there. Then there was a paper in which subtotal scapulectomy was advised. That was a paper by Neeraj. I'll show you a result of that procedure. Then Green and Woodward scapular relocation or scapular transplant at a lower level was described. Woodward is when you divide all the muscles from spine or scapula, bring the scapula down and resuture the muscles downwards. While the Green procedure, which I'll show you in details, is detaching the scapular attachment of all these muscles, bring the scapula down and reattach the muscles there. Then there is one surgery described by Campbell where you osteotomize the scapula about 1 centimeter lateral to origin of the muscles, bring it down and then connect the scapula with a unextendable suture or a wire and keep the scapula downwards. And I have no experience with this, and there are very few reports. So this is a child with Myers procedure where the and a triple failed syndrome. This child has excellent functional recovery. Scapula, if you can see, is higher and significant part has been removed. So if you turn these children and ask them to push against the wall, you will see that there is a significant ringing. And personally, I don't have any experience with this surgery. So my choice is Green's procedure with the Lebowicz modification, and I feel that if you can preserve scapula and provide all the muscles there attachment to act on, why throw away scapula? So we had a debate in POSICON 2013 for proponents of Myers surgery and proponents of scapular preservation, and there was an interesting debate. Ultimately led to conclusion that scapular preservation surgery are far more better than scapular sacrificing surgery. So this is William T, again a British surgeon who described this surgery, and then this was modified multiple times, and I'm going to show you one of the modifications of this surgery. So clavicle has no consensus in management of Sprengal shoulder. There are people who never osteotomize. One of them is my friend Sandeep. There are people who do double level osteotomy. There are people who do clavicular morselization. There are people who just remove the central segment or 1.5 centimeter of clavicle, and people like me who in Cavendish grade 3 patients do single level clavicle osteotomy. And I'll show you what are the complications of clavicle osteotomy and when do you need clavicle osteotomy if you're not done preoperatively. So this is the example of double level clavicle osteotomy. And there are people who, along with the clavicle osteotomy, they also release the tip of the coracoid process so that the brachial plexus is not injured. I think I would reserve this only in a very, very old child. And I have no experience treating any child beyond the age of about 13 years of age. So now I'm going to show you a few surgical steps. The face of this child will be where the face of the patient is. So let's see what we do. Just put about 1.5 to 2 centimeter incision, a skin crease cosmetic incision over the clavicle. Once you dissect the skin and subclavian directly on the clavicle, then you subperiosteally put 2 spikes and just cut clavicle with a bone cutter. You see to it that both the fragments are displaced, and then you would repair the periosteum, close the wound, and make the child prone. If you want to do Sprengal surgery, child should be put on a horseshoe. The non-involved limb can be tied, but the involved limb is kept free and is draped because we want to do a surrogate test whether we have done any injury to brachial plexus or not. And there should not be any extension of scapula. This horseshoe portion should be brought down so actually the neck is in slight flexion. So your job becomes very, very easy. Position of the scapula and amount of the displacement is generally measured before you start the surgery. The incision is a midline incision. Again, that's the original incision was on a curved incision on the scapula, which was described by Green. Again, modified as a longitudinal starting from about C34 to about 2 to 3 centimeters below the normal scapular inferior angle. If you want to have a straight incision, you can use a thread or a cautery and put an incision parallel to that. And one important thing I usually do is I measure the lower end of the opposite scapula and take a single stitch at that level. And I would like to bring that involved scapula to the level of this, because sometimes, after surgery, your scapular position, hand position will move and you don't know exactly where to bring it. So it is always good to initially mark where you want to bring the involved scapula to what level. Whether you will be able to bring it all the way there is something which is an on-table decision. So you have to raise a long flap, and then you have to look for trapezius. See, if you look at in a textbook, trapezius is shown as a very long muscle. But if you look at this is the lateral border of the medial border of the scapula, and this trapezius is present only this much. Generally, the inferior portion is very thin and non-existent. So you will have to start looking for trapezius, not here, somewhere here. So the lateral border of the trapezius has been lifted, and a retractor is placed under that. This is the lateral border of the trapezius. Once you lift the lateral border of the trapezius, rest the incision of the trapezius is erased with cautery from the spine of the scapula. You have to go all the way till angle when the spine turns into acromion process. Once you do that, now you can see that the entire trapezius has been lifted, and you take one or two sutures so that you can mark the trapezius, and later on you can suture. You can see here this end of scapula is prominent, and there is a beautiful undersurface of trapezius, which tells you that you have not damaged the muscle and you have got it absolutely in muscular plane. Once you are there, this is another view. This is the medial border of the scapula. Here is the head of the child, and trapezius has been lifted up with basically the sutures. Now we turn our attention of raising latissimus dorsi flap. Now the child is taken from the head, and this anatomical picture has also been reversed. So here what you do is you find out the superior border of the latissimus dorsi. And once you find that, you trace that till spinous origin, and you cut the spinous origin. Why you cut the spinous origin? Because and you lift the scapula like this upwards on the lateral side. Why you raise the scapula from the spine? Because all the important attachment of scapula comes from the lateral side. So if you develop pocket underneath the scapula, and if you want to work it easy, what you need is you need to divide the scapula from here and raise a flap and with a base on the lateral side. So now the scapula is there, your trapezius is here, and your latissimus dorsi is taken off. Now you go into the medial border of the scapula. Now you cut on the bone and you detach all the medial muscles. Once the medial muscles are out, you can see the medial border is now raw. This is your trapezius, and now you are going underneath the levator scapula. Levator scapula has a broad attachment starting from here all the way up to there. Once you remove the levator scapulae, you will be able to see now homovertebral bar. So this is an homovertebral bar. You can see it's a rhomboid shape. It is thin here, thick here. So first you cut it from scapula, and then you can nibble it out from spine of cervical or lower dorsal vertebrae. Having done that, now you can lift the scapula up. So this is the scapula which is left. This is taken up here with towel clip, and this is the undersurface of scapula, and undersurface of scapula you have got serratus anterior muscle. So then, if the serratus anterior, now you can try and put the scapula down. If the scapula comes easily down at the desired level of your marking, you can bring the scapula down without detaching the serratus anterior muscle and suture the scapula lower. But if it does not come down, you will have to detach the serratus anterior, and after that you bring the scapula down. So once you have removed the serratus anterior, you can see the subscapularis muscle. Before detaching serratus anterior, you will not be able to do subscapularis. So that is what is my contention. So when you are doing a blind subscap release, without going through serratus anterior, you will not be able to reach subscap. So whenever you are going to do a subscap release for anything, for any shoulder issue, you will also damage or interfere with the origin of serratus anterior. So once that is there, there are sometimes adhesions beneath scapula and rib cage. So you would like to put your finger and then do that. But beware that if there is no rib, sometimes you can go in the pleura. And on 2 occasions I have had a pleural tear. I'll show you a case of pleural tear down the line. So this child had significant rib defect. So when I put my finger underneath the scapula with a gentle, simple finger thing, I injured the pleura. There's no need to fear. If you injure the pleura, what you need to do is ask the anesthetist to keep the lung inflated. The length will be about a centimeter or 2. You just repair the pleura, then do an underwater check. I'll show you how to do that, and you don't need to place any intercostal drain. After that, you can remove if the spinous process of the scapula is curved. What you do is after bringing down the muscles in this part, you cut the scapula like this, make it straight, and then you start reattaching the muscles. So the first muscle to be repaired is the last muscle which we detach. So the first muscle repaired is serratus anterior. Once the serratus anterior is attached, so you will require an OS needle. With that, you will be able to perforate the medial border of the scapula because all the muscles will go either on the inferior, medial, or superior border of the scapula. Once the serratus anterior is sutured, you have to suture the lateral angle and medial border of the scapula here with the rib periosteum. Try to see that you don't go again in the pleura and you remain superficial to the posterior portion of the rib. Having repaired scapula, having attached scapula to the rib cage, you would then repair latissimus dorsi first to the inferior angle of the scapula, then back to the spinous processes. Having done that, then you reattach first the levator scapulae, followed by rhomboid major, minor, and then trapezius. And usually you end up with a defect which you will be able to see post-operatively many times. This is how the final picture is. As Sheenam mentioned, that in one of the child, once I did surgery without clavicle osteotomy, and when I turned the child straight, I noted the child had a brachial plexus palsy. But that child did not have radial pulse also. Her pulse oximetry was also abnormal. So after turning the child straight, I went on to clavicle, did a single level clavicle osteotomy. In that case, immediately the pulse returned, but brachial plexus palsy persisted for about 4 weeks. At the end of 4 weeks, the brachial plexus recovered. Then this happened in second case, which I'm going to show you later. And then I decided a surrogate test, which I will describe later. So this child presented to me at age of about 5 years. She had prominent scapula and a significantly restricted abduction. If you see, there is a scar here. This girl was operated for ventriculoseptal defect. You can see her X-ray. This is a sternum which is closed by wires. This was her preoperative X-ray. And this is how she was. She was Cavendish grade 3 candidate. This is 1 year post-op. You can see there is excellent improvement in her shoulder abduction. The scapula is absolutely level. This is her 7-year follow-up X-ray, and this is her 7-year follow-up clinical picture and function. This child, as I showed you, sometimes there will be some issues with the sternocleidomastoid. So this child had a significant torticollis with Sprengal shoulder. This is after surgery. Yes, one important thing is I strapped the scapula for about 4 weeks. Because you have detached the muscle, it is quite painful if you want the muscles to get attached firmly. So I used to initially immobilize for 6 weeks. Then comparing my result, I found that they lose abduction. The improvement in abduction is not as good as I would want. So I reduced the time of immobilization from 6 weeks to 4 weeks. This was removal. On the day of removal, you can see the child has good abduction compared to preoperatively. And this is a 12-year follow-up. You can see there is a normal scapular position. The only thing is this scapula is abnormal, and in few movements where the scapula becomes prominent will be seen very obviously because the muscles are hypoplastic. You can see beautiful shoulders. One important thing again you would like to see that This side of the shoulder and clavicles don't develop well as on the opposite side. Right? So that is one of the things. This is a preoperative X-ray, and this is a X-ray at follow-up of 12 years, and you won't be able to see from X-ray that this child had any abnormality to begin with. Again, a child whom I could not diagnose one thing preoperatively. This child had a good, reasonable cervical spine movements. I could not document her abduction properly. This is her preoperative X-ray. You can see there is a hemivertebrae in thoracic spine. The scapula is elevated. But if you look at this difference, this is a Cavendish grade 3. You can say that this is Cavendish grade 4 because it is close to occiput. But in my opinion, occiput is here, the scapula is there, and the scapula is almost as high as one level scapula on the other side. So this is quite a severe form of these things. This is a serial follow-up that child. If you look at this child, I couldn't bring it absolutely level. It is one grade above. So I could make it from Cavendish grade 3 to Cavendish grade 1 in this particular child. So this is a about 9-year follow-up of the same child. There is a good improvement in abduction. But at this point of time, I noticed that she has developed reduction in cervical spine movement. And when I took her X-ray, I found that she has a Klippel-Feil syndrome. So Klippel-Feil syndrome in very young child may not be possible to diagnose. We don't always do genetic tests. But the diagnosis of Klippel-Feil syndrome is important only for one reason. And you can prognosticate that the range of movement back and correction to the level you desire may not be possible in these cases. And anesthetist should be warned that this is going to be a difficult intubation. So all of you have to remain prepared for this particular two problems which Klippel-Feil syndrome children have. So again, let me show you a child which gave me multiple challenges. So my journey was Sprengal is not very smooth. We had our many issues which are described in literature, which are not described in this literature. So this child came to me with Cavendish grade 3. You can see there is a significant rotation. The scapula is very close to midline. She has a significant restriction of abduction also. And you can see that this is a normal thing. And here you can see there is a deep defect. If you look at the X-ray, this is a preoperative abduction. X-ray, I showed you that there was a deep defect. So this is how it was grossly rotated and significantly high. I would put this as the Cavendish grade 3. And when I put my finger, I ruptured the pleura, I repaired the pleura. And then what you can do is just put a pool of saline and ask the anesthetist to do Valsalva. And if there is no leak, there is no need to put intercostal drain, because here it's a iatrogenic clean cut, and you will be able to completely repair and check it with underwater seal. So that was the first complication in this child. I had already done single level osteotomy because this was Cavendish grade 3. So when I turned this child, again child had brachial plexus involvement. She did not move her fingers well, and her radial pulse was absent and pulse oximetry was abnormal. So I explored the clavicular region again. I did a second level osteotomy. I removed that piece, made it into 2 to 3 pieces, do the morselization, repaired the periosteum over it, and by the time the child regained the pulse. And importantly, child regained the pulse, and even the brachial plexus palsy recovered, because the compression was immediately relieved. So child did not have any brachial plexus palsy, and pulse also returned. So from these patients onwards, I thought that you should always check the pulse before you close down. So now what I do is I bring the scapula down, attach it to the rib periosteum, wait for 3 to 4 minutes before attaching any other muscles. I will then check the radial pulse. If the radial pulse is not there, brachial pulse is not there, I'll bring the scapula about a centimeter higher. I'll reattach it there and recheck for the pulse. And till I get a satisfactory pulse, I will not close the door. And since that surrogate test which I have used, I haven't had any vascular issues or I did not have any brachial plexus pulse. So this child had clavicle morcellization, and this was a simple drain which was for scapula, and this was not a metatarsal drain. See, the follow-up also throws you surprises. Initially, she did not regain abduction very well, but gradually she regained good abduction. This is her functional recovery now. Full recovery of abduction. Scapula is abnormal. As you can see, the shape of the scapula is not normal. But she has developed one thing which is not reported in literature, is a clavicle non. So the papers in which about a centimeter of clavicle or 1.5 centimeter of clavicle is removed, that paper also has not reported any clavicular non-union. But this child has developed a clavicle non-union. She is asymptomatic and she does not want any surgery for this. As I told you, there are people who try to bring scapula by force and attach it with rib cage. Generally, when you remove that wire, the scapula goes back and you generally don't have good result. So to end with this talk, Sprengal shoulder is a rare deformity. You will be fortunate if you have assisted a surgery in your training time. It's more of cosmetic presentation. It is one of the things which is significantly having a late diagnosis. There are very few centers which offer the solution to this problem. I strongly believe that you don't need to throw away any part of scapula because you can always safely put it back and give a excellent cosmetic as well as functional result. My preference is modified Green's procedure with clavicle osteotomy. But if you want to go ahead and do Woodward, which is a more famous surgery, it is the same thing. I was taught how to do modified Green procedure, so I continue doing it. But many of my colleagues are doing Woodward, and I think that's also an excellent operation. The only thing is you have to learn before doing it well. But I don't think I did it that way. I never had an opportunity to learn it well. I evolved it myself, and I was fortunate that I had a nice luck to operate this for 74 times. I'm waiting for my 75th. Hopefully, we'll be able to finish this 75 mark in 2020. Thank you very much for your interest. I think I'll just look at the chats and see if I need to answer any questions.
So we have a few questions.
So, yeah, Premal, that was a great talk and a summary of your huge experience in the field. And I'm sure there are a lot of questions. So, yes, Meet, please take us.
I think Sheenam has asked me any role of CT preoperative planning. I think I have answered that. That the correction depends on the length of the soft tissues. So by knowing the bony anatomy, you don't gain anything. The only thing is you will be able to diagnose preoperative CTs whether the vertebral bar is present or not. And if you know how to excise that bar, whether it is present or not, it doesn't make any difference.
Another question that we have is that as a large number of cases associated with rib anomalies, is there any embryological relationship?
Yes, because this is a condition in which thoracic scoliosis is also part of the gamut of the condition. So rib defects are there, but generally they don't cause any problem except when surgeon intervenes in that rib defect, you will get a pleural tear. So if you are very careful in assessing your cases, and when you have a rib defect, if you are gentle in removing your adhesions, it doesn't make any difference. But it's sort of the Sprengal anomaly, and you can't do anything about it.
Okay. We have a question by Molin, sir.
Yes. So MRI in all Klippel-Feil syndrome is not necessary. The reason being that you won't be able to remedy any of these things. So my strong recommendation for MRI is that if you have spinal dystrophism, that means open spinal canal, suggestive of dystomatomyelia, or any lumbar anomaly. If it's a simple fusion in Klippel-Feil syndrome, in none of the Klippel-Feil syndrome in my series, they had any aether cord. So Klippel-Feil syndrome, I would try to diagnose this radiologically and subject these children to USG abdomen, because there are 3 patients in our series with syndrome who had uh, renal agenesis, unilateral renal agenesis. So in those cases, you would like to avoid renal toxic drugs. So that is the role of MRI and USG abdomen in cases. So in our series, we could, so if the Cavendish is high, you will be able to bring it to at least Cavendish grade 1. So if it is 3, you will be able to make it to grade 1 and make the deformity go away, at least clinically and cosmetically. And you will have an improvement in abduction. So a grade would definitely help you to prognosticate that, if it's a grade 3 or higher, you will be able to tell your patient that you may not be able to bring it down all the way normally. But what I've seen is ultimately the correction depends on tightness of the soft tissue. Because if your levator scapulae is not very long, you will not be able to detach from insertion as well as origin. Because then the nerve supply and everything will get stretched and you will lose that muscle if you force it. So what you can do is you let that scapula be slightly higher. It will you derotate it, so your prominence of scapula from the neck will go away. And no patient has ever noticed that their scapula was not always at the level. It is always when you look for it, you will find that you have not brought it to Cavendish 0. Again, Cavendish 0 was not described. It was described by me in my paper that if you bring it exactly at that level, what do you call it? You cannot call it Cavendish grade 1. So that's where I call it Cavendish 0, which is at inferior borders of when the spine of the scapula are at level. Because as I told you, the scapula is a shorter. So if you bring the inferior level at the same level, actually you're bringing the involved scapula lower than the normal scapula. So you try to bring the scapular spine at the level rather than inferior angle. But spine to measure is difficult, so inferior angle is easy.
So now, Premal bhai, as you said, the vertical height of scapula is smaller. So many a times we have seen that although shoulder is balanced, but the lower end of scapula is little higher than the normal side. So do you explain this to the families beforehand that because while trying to bring both the poles at same level, we might be stretching the soft tissue more,
So you can tell them that it may not come, it may be about within a centimeter of the opposite side. But they will be seeing only the inferior portion, and generally there is no issue because they are more not concerned about the scapular level posteriorly. What they are concerned about is
shoulder
level of the scapular angle which is visible from front. So if you take that away, the patient is going to be happy with recovery of the abduction. If you can provide this too, the patient will not have any issues.
And in all your patients, you require to resect the suprascapular part of the scapula?
No. So when the scapula is curved, if you find a scapula curved, if you bring it down, it will remain little off from the rib cage. So if you create a green stick fracture and straighten that, the scapula will remain flush.
Right. And at times, we have seen that the curved scapula is so much lateral. We need to go fairly lateral, and then we have fear that the suprascapular nerve. So what is your clinical tip to deal with that?
You have to see that you don't go far medially. In that case, what you do is, scapula in upper portion is hypoplastic and a very thin bone. So if you cut the medial side, which is a thicker, say about 2/3 of that, if you cut, the rest of the scapula, which is on the lateral side, which is close to your supraspinatus neurovascular bundle, suprascapular neurovascular bundle, that will be a green stick fracture there, and it will straighten up. So you don't need to go and cut all that length. You just cut lateral medial 2/3. The rest of it will straighten up on its own because it's a very small incision.
One more thing I have observed in a few patients that they had clipal fail and a dorsal cervicodorsal scoliosis.
Yes.
So the elevation of the shoulder is not only from the undescended scapula, but also from the
Yes,
Fine.
so
So
when you
how do
have
you
a
actually look at the
significant,
family?
yes, so when you have a significant dorsal scoliosis, I have written in the paper that you have to explain to the parents that scapula, even though will be at level, it will always remain prominent. So you will be able to tell that patient that I will bring the scapula, but the shoulder will remain high, but the angle will disappear. So that is some preoperative counseling you have to do. I had two patients in which they required, in my opinion, they required scoliosis correction, but none of them were ready for that. So I don't have any patients who underwent
Fine surgery.
surgery after scapular flexion.
And my final question, like I have seen in a few patients where we have leveled the scapula at the time of surgery, and in the follow-up, it has migrated a little bit proximal. So do you recommend to kind of overcorrect and it will come to a level, or what has been your experience?
No, it doesn't migrate. So what happens is sometimes you have done a very tight suturing. You may be very happy pre-operatively, but in about 6 weeks time it will go. When you remove the strapping, 4 to 6 weeks, it will be slightly higher. But if after that it doesn't go up.
And you use this Vicryl only, right, to tie?
Yes, it's always absorbable. Nothing. I have never used an unabsorbable suture ever.
Perfect. Yeah.
It's only
Meet
Vicryl
for
one number OS needed.
right. Meet, please.
Yes, sir. So we have a few more questions. Question by Dr. Sheenam. How is the spring traction given?
No, there's no need to give string take. That's an obsolete method. I just showed you because I had one of the patients who had come unsatisfied with the results.
Okay. And sir, was there what was the age of the patient where we usually see brachial plexus palsy in post-operatively? I mean, is there an association with that?
No. Brachial plexus palsy is a surgical thing. It's an iatrogenic injury. So it can happen at any age in any child. So that's why there are people who recommend clavicle osteotomy. There are people who do not recommend. Sandeep in his paper has no brachial plexus palsy without any clavicle osteotomy. And in my paper, we had clavicle osteotomy and still had brachial plexus palsy.
Okay. And sir, what has your experience been with sagittal osteotomy of the clavicle?
Sagittal osteotomy of clavicle. What do you mean by sagittal osteotomy? I read that question, but I didn't realize what is that.
So Sheenam, like we all, as Premal Bhai mentioned, we do a single level, simple osteotomy. There might be some fancy osteotomy of, there's probably Premal Bhai, it's a transverse kind of, oblique.
It's a sagittal osteotomy, it's for scapula actually. So that's a scapular osteotomy as a correction of Sprengal deformity. So you do a sagittal osteotomy of scapula 1 centimeter lateral to the medial border. So your all short muscles remain there. Then you can bring the scapula down.
No. The Campbell's one,
Scapula to
right?
scapula. So this is not a sagittal osteotomy of clavicle. I think it's a sagittal osteotomy of scapula.
Sheenam, did you mean scapula or clavicle? And if it is clavicle, then explain what it is.
Sir, I have read a paper where they have cut the anterior part of clavicle.
Anterior part?
Yes, sir.
Anyway, you share that paper with us, and I'll share it with the Premal Bhai. It's something new. I have never heard of this.
Okay.
Yeah. Further question, Meet? Any questions?
That's it, sir.
That's it.
Yes, sir.
Fine. So Premal Bhai, I don't know why my camera is not seen. Something is wrong. But thank you very much for that great talk. And this will be there on OrthoTV as well as our channel. So, and it will be link would be circulated. So many more people would be able to see it later.
Okay.
Thank you very much.
Okay, thank you. Have a good day. Bye-bye.
Bye-bye. Take care. Bye, everyone. And if you have any further question, you can share with Dr. Meet, and we'll ask to Dr. Premal Naik personally and get back your answers. Yeah. Have a good day.